Hello and good evening, everyone. Welcome to our 47th Blue Earth Virtual Seminar. Blue Earth Virtual Seminar is a platform that allows healthcare professionals to discuss current management updates of different health-related topics for better patient care. And this platform is brought to you by Blue Earth Ethiopia, a medical consultancy company founded by medical doctors and a computer engineer. And we aim to be an influential healthcare leader in creating a skilled community through easily accessible knowledge in preventive medicine. And this session is organized by Blue Earth Ethiopia in partnership with Ethiopian Society of Hematology and Oncology. I would like to also mention that for the past 7 or 6 virtual seminars, including this one, the Ethiopian Society of Hematology and Oncology have been providing us with amazing presenters presenting on different important topics. And I'm your host, Adam Getachew. I'm the co-founder and CTO at Blue Earth Ethiopia. And we are honored to have Dr. Mulugeta here with us to give us a brief discussion on the clinical assessment and differential diagnosis of a child with suspected cancer and when to refer. To give you a little background about Dr. Mulugeta, Dr. Mulugeta is an associate professor of pediatrics and child health. He's also a pediatric hematologist oncologist at the University of Gondar Comprehensive Specialized Hospital.
Thank you for coming to attend this important session. So this session will be on early detection of childhood cancer, mainly on how to diagnose and detect childhood cancer early and refer to a treatment center. Where in the month of February, it's a special month for the cancer community. Most importantly for the pediatric cancer community, it's a cancer awareness month, including for adults as well. We have celebrated the International Cancer Day in the 4th of February. And we'll continue doing awareness creation and campaigns throughout the month of February, and February 15th will mark International Childhood Cancer Day. So it's a good opportunity for us to gather tonight to discuss about early detection of childhood cancer. So this is the outline of the presentation. We'll see the epidemiology of childhood cancer briefly, and then some introductory slides will be presented, and then we'll deep dive into early detection of childhood cancer, and then common presenting features and mimicries of childhood cancer. And then we will also briefly discuss about common presenting features, and then when shall we refer children with suspected cancer to a treatment center. And then briefly we'll also mention about how to establish a diagnosis of childhood cancer, and then finally we'll see the summary. These are the learning outcomes. So at the end of this session, we'll be able to understand symptoms and signs of childhood cancer, and then we'll be able to recognize conditions that mimic childhood cancer again as a differential diagnosis. We'll discuss briefly about common presenting signs and symptoms, and most importantly, we'll discuss about the red flag symptoms and signs of childhood cancer, and then when shall we refer for evaluation. And also we'll understand the importance of early referral. How would that affect childhood cancer survival will be discussed. And then before referral, how can we stabilize children with suspected cancer? And the do's and don't do's will also be discussed. So as an introduction, cancer is generally common in adults. It's not a common thing in children, but still it accounts for majority of disease-related diseases, specifically in high-income countries. Even in low-income countries, it's now becoming public health, public health significant burden in children and adolescents. While the epidemiology is shifting, and while mortality from infectious and communicable disease is being controlled, at least to some extent, the contribution of cancer to childhood deaths is ever increasing. So one point here is it's really challenging to diagnose cancer in children at early stage because mainly the symptoms, the presenting signs and symptoms are mostly non-specific, and then they can be, explained by common childhood cancers. So for a primary care provider, like most of the attendants tonight, it's very difficult to suspect childhood cancer at its early stage of presentation. So despite the low incidence rate, pediatric cancer remains the leading cause of disease-related mortality in children. And most importantly, in low-income countries like ours, the burden is really significant, and then the mortality and the morbidity associated with it is really big. So signs and symptoms of cancer are relatively non-specific. We have said that it's really non-specific, and it might mimic variety of common problems, mostly infections, inflammatory conditions, systemic diseases might mimic presentation of childhood cancer. So for an oncologist like us, the index of suspicion for cancer is really high because we are dealing with children with cancer, and whenever we have a child with given symptom, the first thing that will come into our mind is childhood cancer. But for a primary care physician, the opposite is true. This statement is supported by research, and most primary care physicians, nurses, where these children, will be visiting for the first time, they have a low index of suspicion because for a general practitioner or for a physician, a pediatrician, or a nurse, it might take long time to see their first case, and the next case when they see it, it will be another cancer. So it will be very difficult for them to, suspect childhood cancer, at early stage. So every time we need to think about it, we need to think the possibility of it, that childhood cancer, it exists, and then symptoms are vague, and mostly they mimic common childhood problems. So healthcare providers, mainly nurses at a health center, at a health post, they are the children's first point of entry. And then if they don't correctly recognize and respond to these early signs of childhood cancer, significant poor outcome will be associated with this delayed referral and then delayed linkage. And then most studies, they show that 83% of nurses, they didn't receive training on pediatric cancer. They didn't receive that. That means they don't have any knowledge or skill to identify early signs of childhood cancer, and they don't have the necessary knowledge and the skill to early initiate referral for children with suspected cancer. So insufficient knowledge about warning signs and symptoms of childhood cancer, it leads to improper diagnosis, delayed diagnosis, and loss of many lives of children. So the purpose of our session tonight and similar general early cancer detection sessions is to enable primary care personnel, like most of you in this call, to identify children with cancer, to enable timely referral, and to give children with cancer a chance of cure. One of the major difference between pediatric cancer and adult cancer is that, in adults, there are well-established prevention strategies and there are well-established screening tools. But in the vast majority of childhood cancer, there are no effective screening tools and there are no effective prevention strategies. The only way to have a good outcome is to detect it early and to treat it early and then to complete the treatment timely. In doing so, childhood cancer can be curable. Like in high-income countries, more than 80%, 90% of children with cancer are cured because disease is detected early, treated properly, and then it's associated with a high degree of survival. But unfortunately, very unfortunately, we can't tell the same story in low-income countries, including our country. So briefly about the epidemiology of childhood cancer, the incidence in Africa is around 99 cases per million for boys, and then 73 cases of cancer will be diagnosed for per million in girls from global global report. And more than 80 to 90% of children with cancer in high-income countries are cured, or they will have long-term survival, whereas the opposite is true. Like majority of children in low-income countries, low and middle-income countries, they don't survive long. And then this number is really low. And in some countries like ours, it doesn't, pass 30% limit. So the major contributor for this is delayed diagnosis and treatment abandonment. For today's session, we'll discuss about delayed diagnosis and then delayed referral. So patients in Africa, not only in Ethiopia, but in sub-Saharan Africa in general, they present with advanced stage disease. And when the disease is advanced, mortality will increase. And then it will be very difficult to cure. And it might take a lot of effort, might take a lot of resource, and it might take again a lot of, patient has to come to the hospital frequently, and then mostly it will end up in days. But early warning signs are associated in 85% of childhood cancer. When they present, they had presented with early warning signs, which might lead to an early diagnosis. This is the leverage point, is this one. Almost 85% of children, when they present, they had early warning signs. If we can pick these signs, and if we can detect childhood cancer at early age, there is a possibility to achieve a higher cure rate, just like high-income countries, because most of the childhood cancer treatment protocols and the chemotherapy agents, they were there for so many years now. There is no new drug, there is no new innovation, but what's making the difference is early detection, early treatment, and treatment completion. So when you see again the epidemiology, more than 400,000 cases of childhood cancer per year are diagnosed globally, and then 90% of these cases are from low-income countries like ours, low and middle-income countries. And the survival rate, just to repeat what has been said earlier, it depends, unfortunately, it's so unjust, but it depends on the place where the child is born and lives. Like in high-income countries, 80%, less than 30% in low-income countries. In Ethiopia, there are no strong data because of lack of, cancer registry. But unpublished reports suggest that survival rate in childhood cancer is less than 30%. So these are, epidemiology-wise, these are the commonest childhood cancer across age groups. In children, age matters to determine the epidemiology. So mostly it's leukemia, and mostly it's brain tumor, generally speaking. But there are some geographical variations, like in sub-Saharan Africa, predominantly lymphomas, including Burkitt's lymphoma, is the dominant type of childhood cancer, whereas brain tumor is not that common for a very different reason. But generally speaking, childhood cancer, it varies based on the age of the child. As age increases, the disease will change. Like in adolescents, we have Hodgkin's, we have sarcomas, and then we have bone and soft tissue tumors. But during infancy and early childhood, we have leukemias, we have retinoblastomas, Wilms tumor, and the likes. So because of different issues that we will discuss later, most patients in low-income countries, including ours, will present at advanced stage like this. So it's a common finding, or a common scenario, to see children to present with advanced stage of the disease, where the disease already incurable or difficult to treat. So why it's challenging to diagnose childhood cancer? So initial presentations, like we said earlier, they are vague, they mimic common childhood illness, and then it's very difficult for a primary care provider to suspect childhood cancer, because the incidence itself is low, but for a solo practitioner like most of you here, it might take a long time to see one child with cancer, and then to see another child with a different cancer. Might make it very challenging to have a index of suspicion for practitioners. But it's always good to consider the possibility of childhood cancer in every symptom, especially when the symptom is persistent, when the symptom is not responding to standard treatment, when the symptom is atypical, or when there are warning signs that we will see them in a bit. So timely cancer diagnosis in children is extremely important. It's just like making a disease curable. If you make it to detect early, if you diagnose it early, that is curable. But if it's diagnosed late, that's incurable. So the difference is really huge. So many pediatric cancers are highly curable. Majority of them, they are highly curable if they are diagnosed early and properly. And then that would result in diminished intensity of therapy, fewer complications from the treatment, and low cost of treatment. But when it is detected at advanced stage, it will be very difficult to achieve cure, and it might result in days. So when we see the journey of a child with cancer, what determines incidence, what determines survival is like, we have a patient with cancer, there has to be a high index of suspicion, there has to be proper evaluation without delay, and then timely diagnosis. This will determine the incidence of childhood cancer. Those numbers that we have mentioned earlier, for example, in Ethiopia, it's estimated to be like 12,000 children per year are expected to be diagnosed based on extrapolating data from another East African country. The expectation is there will be 12,000 children per annum, but truly what's coming to the treatment center is really low. It's really low, maybe 2,000, maybe 3,000. So the incidence is affected because most children are not properly diagnosed, they are not properly evaluated, and they will not count to the incidence. So what determines, right after diagnosis, there has to be proper correct diagnosis with the proper method and personnel, and then the right treatment timely should be given to achieve cure and to improve the quality of life. Along the way, there are different contributors to achieve cure. There are different contributors to achieve cure. So why is early detection important? Why are you discussing about early detection? Is, we have mentioned it earlier, late diagnosis and treatment abandonment are frequent problems. There are so many researches which support this late diagnosis and delayed referral and treatment interruption and abandonment are associated with a very low outcome in children with cancer from LMICs. So if you detect it early, we can optimize survival probabilities, and we can achieve a better cure for children with cancer. So there are different contributors to this low outcome. It might be associated with treatment availability, related to the cost, but delay in detection and diagnosis is a major contributor again. So early detection is the low-hanging fruit for us because there are no effective cancer screening methods in children, unlike adults, and the vast majority of children with cancer, childhood cancer, is not preventable. There are, except for few, for the vast majority, there is no effective prevention strategy, and outcomes is dictated by the time of detection. If it's detected early, late, there will be a poor outcome. So early diagnosis, appropriate early diagnosis and treatment require primary care physicians and parents to know early symptom of childhood malignancy, because it all starts in the community, it all starts in the family, it all starts in the primary healthcare unit. So it's not unusual to hear parents reporting that I knew that my child has some serious illness. I told him or I told her, but they didn't consider it. We have to consider, we have to take proper history, we have to take detailed, thorough physical examination, and we have to always consider childhood cancer in symptoms and signs that are not explainable by common childhood problems. So we need public education, we need professional education like today to eliminate this disparity in cancer survival. So pediatric cancer is not preventable, but it can be detected at early stage and it can be curable. So what's important here is early detection is a game changer, because like we said earlier, the difference between a high income setting and a low income setting is only the system, the health system, and supportive care. In terms of availability of chemotherapy, there are issues, but still, if it is detected early, childhood cancer is generally curable. So there are some technical definitions to this. Delay in diagnosis of cancer, it's defined as the interval between the onset of symptoms and the confirmation of a cancer diagnosis and initiation of treatment. If this interval is prolonged, that's called delayed diagnosis of cancer. And it's a significant health problem that has contributed to decreased survival rate in children in LMIC. So it could be from patient delay or physician delay. Every story has two sides of the coin. So it could be sometimes patients might came delayed, or the health system might create the delay itself. So it's good to tackle both. So total diagnostic delay is the time interval from detection of the disease to its diagnosis, and it will be contributed by patient delay and then physician delay. So when a child is sick, especially in countries like ours where people live in a community, so they tend to consult family members, society, and these traditional healers. So that will take its own time. And then after that, they might seek professional help that will contribute again for another delay. And then the third delay would be time to treatment. Getting access into specialized institution by itself, there are so many bureaucracies, there are so many red tapes, and that would also contribute for delayed diagnosis in children. And the treatment duration itself and related factors associated with treatment would contribute for poor outcome in children. So along the way, there are interventions that can be done and to curb this problem. So there are few studies done regarding delayed childhood cancer diagnosis in our country. The first one is from IDER, and in 2019, they have demonstrated that close to 70% of childhood cancer patients had delayed diagnosis. Major contributions are low parental education, lack of awareness, and also use of alternative medicines, including holy water. So another study from Gondar, they demonstrated is much lower, but still it's very high. 44% had delayed diagnosis, and median delay was 68 days. So in 68 days, in 2 months, in 3 months, a curable cancer would be converted into incurable terminal illness. This is how it is significant, in terms of, survival and outcome. So when you see this different research, like there are 2 papers from Nigeria, and in this one, if you can see it, the significant delay, the lag time was significant, and there was a physician lag time was 8 weeks, and parental lag time was only 2 weeks. Parental lag time, the parents reported to the clinic on a timely basis, but there was significant physician lag time with an overall lag time of 15 weeks. But another study from the same country, Nigeria, demonstrated the opposite finding. Zero significant parental delay, and the physician delay or the health system delay was a little bit shorter than the previous report. So we have to act on both sides to decrease this delay in diagnosis. So parental factors are there from those studies. They have demonstrated that the failure to recognize the symptoms, delay in seeking health care, and then the alternative medicine, self-medication, traditional healer, and religious options are there, and financial constraints contributed for delayed diagnosis. Health system factor. If you see the health system factor, incorrect or delayed diagnosis is a major contributor. Correct or I'm sorry, incorrect as well. Even here, children with different conditions, they might be seen first at different specialty centers, like a child with osteosarcoma or swelling in the leg could be first seen at a regular OPD, then linked to the orthopedic side, and then linked to a regular OPD where it might take months to settle the diagnosis. So a child with any suspicious sign of cancer should be linked preferably to a pediatric oncology center where tests and investigations will be facilitated on a timely basis to avoid, delay. But what's happening is like patients will come to the oncology center after rounding of many different specialties. And then the other reason was the delayed referral to an appropriate treatment center. So unnecessary investigations and delays at a primary hospital or referral hospital would result in delayed diagnosis. So how can we make an early diagnosis of childhood cancer? There has to be an index of suspicion, and also we need to focus on high-risk groups. Even if there are no well-established risk factors for childhood cancer, there are some high-risk population in whom we need to, intensify the surveillance and then the screening. The other one is recognizing the red flag symptoms and signs of childhood cancer. It's very important to diagnose childhood cancer early. So who are the highest groups? There are few, like children with certain conditions, cancer predisposing conditions like neurofibromatosis, whom they're, at increased risk of developing different types of cancer, and children with numerical or structural chromosomal abnormalities, in this case, Down syndrome, Fanconi anemia, and other chromosomal breakage disorders. They are at a very high increased risk of developing cancer. So, we need to give due attention and focus for such kind of patients. This also includes children with acquired or inherited immunodeficiency states. So what it takes is proper history and thorough physical examination. These two, alongside with the family history, they want, there is nothing that can replace these methods like proper history, detailed physical examination, and family history. In this picture, as you see, there are capillate spots, multiple hyperpigmented skin lesions, and axillary flickers. But if we don't take a proper look into the whole of the patient, we might miss such signs and symptoms that might lead us into a suspicion of some form of cancer. So siblings with malignancy, specifically twins, if one twin had history of cancer or the other, that should be, a high-risk group. That should be identified as a high-risk group. Specifically for some cancers, there's increased risk of, passing the genes in families. This is mostly it works in retinoblastoma and other childhood cancers. Congenital syndromes like Beck-Wiedemann and Wagner syndrome, these are cancer predisposition syndromes. Children could present with one or combination of these signs, but they should be followed, serially before they develop advanced disease. If they had treatment for malignant disease in the past, that would also make them a high risk. So these are the symptoms that might mimic, common childhood illness. Most of childhood cancer manifestations, they mimic common symptoms in children and common signs in children, but they could be manifestation of cancer. That's why we have to always put in the back of our mind, this could be some form of cancer. Generalized malaise and fever alongside adenopathy could be commonly viral etiology in children. It's a common phenomenon to have this combination of symptoms. But it could be leukemia and lymphoma as well, And some neuroblastomas could manifest in a similar way. So we have to put these differentials when you have a child with malaise, generalized sickness, someone who is not like himself, and alongside with fever, adenopathy, we have to consider these differentials. In the head and neck region, if there are headaches, nausea, vomiting, brain tumor should always be suspected. And then the only presentation for a brain tumor could be seizure, with or without additional symptoms. We'll see it later on, how to approach a brain tumor, specifically associated with headache. So all these symptoms, they are common, but they are common as a manifestation of common diseases. But it could be, again, a manifestation of childhood cancer. That's why we have to always think about childhood cancer when a child had this symptom in isolation or in combination. So the general point, like I said earlier, nothing replaces a thorough medical history, a family history, and a physical examination in approach of a child with suspected cancer. If you listen to the families, if you listen to the caregiver, and if you do detailed family history analysis and then detailed physical examination, we will understand that this is not something common, this is not something simple, rather this is something serious. So these are the symptoms of childhood cancers, and then their proposed, diagnostic tests. Like, for example, if someone had weight loss which is sudden, this could be manifestation of any type of malignancy. So the approach might be, abdominal ultrasound alongside with proper history and physical examination. Abdominal ultrasound might help to check on the presence or absence of intra-abdominal process. A child who had PTK will be approached as with CBC and peripheral smear to identify presence of leukemia. It goes like this. So this is just a summary. Any child with an eye issue, whatsoever is the eye issue, should be checked by an ophthalmologist. It may not be feasible in our setting, but at least whoever is evaluating a young child with an eye issue, they have to think that this could be something serious. They could have an eye infection, they could have a trauma, they could have, some other issue, but if they have white lesion in the eye, or if they have alignment change, or if they have any proptosis or anything, whatever we do, we have to make sure that they have, they should come back for checkup. They should come back for check. If possible, they have to be linked to an ophthalmologist or a pediatric oncology center. But if the suspicion of retinoblastoma is not significant, and if you are considering some other disorders, even if you treat it, you have to make sure that they will come back for a checkup. So intra-abdominal mass, unlike any other, mass, this has to be approached differently. Any mass in the abdomen which is palpable should be considered as malignant until proven otherwise. This is the old teaching, and it's still valid. So the approach would be doing ultrasound. So what are the warning signs for early childhood cancer? So unexplained pallor and loss of energy could only be the manifestation of a leukemia or some other tumors, mostly leukemia. So children, they tend to play less, they tend to stay at home, and they will have a shorter, brief duration of playfulness, and they will become pale and pale. So this could be the entry point for leukemia. Or another warning sign could be any lump, any mass, any swelling, anywhere. This has to be seen as a warning sign for childhood cancer. The point here is just to make sure that there is no cancer. If there is cancer, we have to detect it early, but we have to make sure that we are excluding serious conditions like cancer in such scenarios. And recent unexplained weight loss, unexplained fever, and persistent constitutional symptoms, night sweat, and then weight loss alongside with fever could be a warning sign. Easy bruising or bleeding, again, should be seen seriously. And then ongoing pain, prolonged pain, limping, swelling in the extremities, frequent headache with vomiting and focal neurologic signs, or any eye change should be considered as a warning sign for childhood cancer. When we see the common signs and symptoms, we have said earlier, childhood cancer may present with symptoms shared by other common childhood illness like tuberculosis, like visceral leishmaniasis, like infectious mononucleosis, HIV. These are common in children, or pyogenic lymphadenitis, osteomyelitis. This might mimic childhood cancer or systemic onset. These are really confusing. Most of the common childhood illness, they might confuse with childhood cancer. That's why it complicates with timely diagnosis. So when we see the constitutional symptoms that could be presenting feature of childhood cancer, fever with weight loss and the night sweats is as most commonly reported constitutional symptom. And then the fever generally is common in children and it's rarely associated with cancer. But when the fever is not responding for the usual treatment, or when it's not following the usual course, we have to suspect serious conditions like childhood cancer. So we need to have a plan. The diagnosis should be made, and that should be treated, and it should respond for the expected duration of time. Any fever which is persistent needs proper workup, proper evaluation, not only for cancer, but for some serious conditions, including cancer. So among children with prolonged fever of unknown origin, 10% of them were found to have leukemia and lymphoma. So one differential for fever of unknown origin or prolonged fever is childhood cancer. When the fever is present without additional symptoms, it might be difficult, but mostly when fever appears alongside additional symptoms like bleeding, manifestations, symptoms of anemia, and then clinical signs like organomegaly, the diagnosis might be straightforward. So more than one half of children with leukemia have fever at presentation. And when you have a child with persistent fever, we need to do detailed physical examination, including examination of the lymph node region, checking for signs of anemia, looking for bone tenderness and hepatosplenomegaly. So the initial diagnostic workup, like wherever you are, how you are approaching a fever is almost similar. I would imagine like you'll start with proper history, physical examination, and then the most commonly prescribed investigation is a CBC, a full blood count. And if there is any suspicion of leukemic process, a peripheral blood smear would be done. But depending on your clinical approach, if you are dealing with a child with malaria, suspected malaria, the approach would be different. If you are dealing with a child with urinary tract infection with fever, the approach would be different. But when there are suspicions of childhood cancer, like leukemia, you have to include peripheral blood smear. If you are in a center where there is a pathologist or someone experienced in reviewing a peripheral blood smear, that should be part of the workup, including LDH and uric acid. But if your center is not able to do these tests, there's no need of delaying the diagnosis. And then you can just refer the child for unsettled cause of fever, or like the traditional IMNCI. It's really invaluable to send the patient with a very severe disease category. There's no shame in that, because you can't settle the diagnosis in your center and then you don't know what's going on. So the only way you can send is like he had a very severe disease, possibly leukemia, so he needs further workup, rather than delaying the investigations in a center where there are no abilities. Weight loss is another constitutional symptom. And in most children, weight loss is not associated with cancer, but if it is a continued unintentional weight loss, that should be suspected as a cause or a manifestation. So as a manifestation of an underlying malignancy, specifically if it has, associated anemia, pallor, lymphadenopathy, organomegaly, unexplained fever. When they came in multiple, I think that will be straightforward. Or it will be much easier to suspect cancer when a group of signs and symptoms appear together. The problem is when they appear in solitary manifestation, that might be a little bit difficult. The other manifestation is fatigue and pallor. Is usually anemia, but there are non-hematologic causes, but we are discussing about cancer, so fatigue and pallor are manifestations of anemia. And then initial testing should be initiated immediately. If a child has pallor, like on the image on the right, he has severe palmar pallor, so I have to initiate a workup after proper history and physical examination. Mostly the physical examination and the history will give us a clue about the underlying cause of the anemia, because the anemia, the pallor, is a manifestation of an underlying disease. But regarding the workup, you can initiate CBC and see whether the other cell lines are affected or whether the child had isolated anemia. And then that will give you a clue about the next step of management or referral. So we have a case here. We have a 14-year-old male who presented with ear pain for 1 week and lateral neck swelling for 3 weeks. He has had a low-grade fever for 2 weeks. On physical examination, there is no discharge, no tragus tenderness, a 3x4 non-tender smooth surface mobile right lower cervical lymphadenopathy, treated with antibiotics for 10 days, came back with fever and malaise. Still the swelling had persisted, and he was treated this time with antimalarial. So this will lead us into the next manifestation, lymphadenopathy. So most children have palpable small cervical or axillary lymph nodes at some point during their childhood. It's a common finding, and it's not worrisome at all. But the risk of malignancy will increase when the nodes are bigger, when they are associated with other additional manifestations, and when they are not responding for conventional treatment. That would be a concerning sign, and usually associated with, as you all know, with leukemia, lymphoma, and neuroblastoma. So most commonly, it's associated with this hematological malignancies, but it could be a manifestation of metastatic disease, specifically in neuroblastoma. So what clinical features are worrisome for malignancy in children with peripheral lymphadenopathy? This slide is from the UpToDate. It's a well-summarized report regarding concerning features of adenopathy. So if there are systemic symptoms together with the lymphadenopathy like fever, night sweat, weight loss, this has to be seen seriously. It may not necessarily be cancer, but it could be something serious like tuberculosis, HIV, infectious mononucleosis, but cancer is also a possibility in this scenario. When the nodes are in the supraclavicular region, be it in the right or the left, that's always cancerous or pathological. And then it might, it should initiate an immediate biopsy evaluation. And when the lymph nodes are diffuse and multiple, or when they are fixed and non-tender in the absence of other symptoms, this has to be seen as well seriously. Clinically significant lymph nodes, they will be defined based on the size and the site again. And if there is an abnormal chest radiography, one good point here is like you need to have a chest X-ray whenever a child had, a lymph node which is big enough to be considered as, serious or worrisome. We need to have a chest X-ray to look for the presence of mediastinal mass. Or if the lymph nodes are associated with abnormal cell count, abnormal full blood count, or cytopenia, that would be also another reason to be worried. So when shall we submit a lymph node for biopsy? The next question. So, when the lymph node enlargement is persistent or progressive, these are more subjective, but generally anything which is persistent more than 2 weeks or which is not responding for the initial treatment for more than 2 weeks should be considered as, persistent, and we should keep an eye on the next step of management or workup. Any big lymph node, more than 2.5 centimeter, supraclavicular adenopathies are always pathogenic. And lymph node enlargement with systemic symptom needs a lymph node biopsy. Final cytology is also a good option, but biopsy is always a gold standard. So after another 2 weeks, back to our case, after another 2 weeks, the lateral neck swelling has increased and started to lose weight, and he lost already his appetite by then. And then he went to head and neck clinic where the biopsy was done from the lymph node, and it suggested lymphoblastic lymphoma linked to the pediatric hemato-oncology unit. So now he's on his last phase of treatment. But the delay, you can see like there was a significant delay until he gets the right diagnosis. The second manifestation is a thoracic mass in children. So virtually all primary intrathoracic tumors, they arise within the mediastinum, whether in the anterior, middle, or posterior. They all are malignant thoracic mass. They arise from the mediastinum. Sometimes they could be asymptomatic, but mostly they are associated with oncologic emergencies, superior mediastinal syndrome, and they could present with cough, shortness of breath, and facial and neck swelling. So anterior mediastinum is a site for teratomas and then thymoma and T-cell leukemia, and the middle mediastinum is a site for lymphomas, generally Hodgkin lymphoma. Posteriorly, we have neurogenic tumors. So depending on the site, the clinical manifestation would be variable, but any child with unexplained respiratory symptoms or persistent respiratory symptom needs a proper workup and investigation. The other manifestation is bone and joint pain. It's a common complaint among children, and then they usually present to primary care physician with pain in the joint, pain in the bone. But from different reports, bone pain and joint pain was reported as an initial symptom of malignancy in more than half of children who were referred to the National Cancer Institute. So it's a common problem in terms of benign disease, but it's also one of the commonest manifestation of childhood cancer, mostly leukemias and then bone tumors. So the pain is severe here, and it interferes with their sleep in the majority of the cases, and then usually differentiating malignant, painful bone lesions and joint pain is very difficult from a common cause of joint and bone pain in children. The most common mimicry is juvenile idiopathic arthritis, where most children would present only with bone pain and joint pain without alterations in other clinical finding and cytology, CBC, where a primary care physician will start on a steroid or other treatment that might affect the diagnostic workup of a child with leukemia. So our next case will lead us to how important is differentiating bone pain of malignant from non-malignant causes. 3 and 7 months old female admitted to the main pediatric ward with a diagnosis of, actually he's a boy, with a diagnosis of disseminated tuberculosis to the lung, pleura, lymph node, and vertebra, after he presented with a complaint of back pain, extremity pain, and progressive bilateral lower extremity weakness. His counts were pretty normal. The CBC was normal by then. So he was started on anti-TB for the same diagnosis. And after a week of anti-TB, he returned with high-grade fever, cough, and vomiting. He still had the gibbous deformity on his back, and now he's paraplegic. His full blood count revealed a white cell of 2,900, a hemoglobin of 6.9, and a platelet of 133,000. Pediatricians still consider this should be tuberculosis, but initiated hematology consult, and then we will see how important is dealing with the bone pain, and we'll come back with the case. So patients with primary bone tumors usually present with a localized pain at the site of involvement, usually preceded by, there will be initially pain, no swelling, but later they would have a swelling. That's the main reason for delayed diagnosis in bone cancers. They would have only pain, there is no swelling. By the time the tumor has gone through the periosteum, resulted in a swelling, it's too late, or the disease is already advanced. So More than 80% of children with bone tumor complain pain that may be intermittent initially, that might interfere with their playing and exercise, but later it will increase in severity and become a constant, non-remitting pain. But when the pain is diffuse or when it involves multiple sites, it's a feature of leukemia, endoing sarcoma, or neuroblastoma. So it's a feature of acute leukemia. That's why every time when you have a child with diffuse involvement of bone pain, you have to think about the possibility of acute leukemia. Differentiating bone pain of leukemia from musculoskeletal origin may not be always easy, and that's why it could contribute for delayed diagnosis. But with proper history and physical examination, we might be able to differentiate these two conditions. So conditional symptoms such as night sweating, weight loss are more likely to present in children with cancer, but in other conditions like other non-malignant cause of bone pain and joint pain, these conditional symptoms are not common finding. Whereas laboratory findings suggest malignancy, like in terms of elevation of ESR, elevation of LDH, and this would speak for tumors including leukemia, neuroblastoma, and then sarcoma. And then thrombocytosis is a feature in inflammatory conditions like GIA, but thrombocytopenia is a feature of leukemia with bone pain. So how do you evaluate bone pain and joint pain? We should be concerned when there is inability to use that limb or refusal to walk, if the pain is severe enough that will awaken the child from their sleep, if the pain is severe and continued at rest, or if any child whose age is less than 3 years had a bone or hip pain, that should also be an indication to initiate workup. And then the palpable mass on examination is another indication. The evaluation will include a plain X-ray, a complete blood count, C-reactive protein, lactic dehydrogenase, and then the uric acid. So it's essential to perform a bone marrow evaluation before beginning treatment with steroids, because steroids can induce remission in some forms of leukemia. Even a shorter course of steroid might change the bone marrow finding. So whenever you have a child with persistent bone and joint pain, and if the symptoms and signs are not explained by inflammatory condition or systemic conditions before initiation of steroid, we have to discuss with an oncologist to decide on the need for a bone marrow examination. So our second case, bone marrow was done and it revealed acute leukemia. Spine CT suggested diffuse lytic vertebral lesions with collapse. So that was not tuberculosis, rather acute leukemia, which was initially, the CBC was normal. That could happen quite often. Bone marrow manifestations or bone lesions and then bone pain would be an initial event, even in the presence of normal CBC. So whenever you have a diffuse bone involvement, acute leukemia should be a differential diagnosis. So the next symptom is headache. It's a common symptom in general pediatric symptom practice. And then intracranial tumors are rare cause of headache in children generally. But we have to consider brain tumor, intracranial process, space occupying lesion as a differential when the headache is persistent and then when it gets worse through time and when it's associated with other neurological manifestations. Not only neurological manifestation, but if it's associated with early morning vomiting, visual change, and then the personality change, focal neurologic deficit, that has to be considered as a brain tumor until imaging revealed the true nature of the disease. So different research suggests that the best screening method for a brain tumor is a careful history. Proper history and neurological examinations will reveal the true nature of the disease, and then this will be followed by a neuroimaging. So when should be, headache should be concerned for a brain tumor? If it is persistent or recurrent for more than 4 weeks, or headache in a young child, headache that is severe enough to awaken the child from sleep, and headache associated with vomiting, and headache plus any form of neurologic deficit would be a concern for brain tumor. There are some, diagnostic strategies for brain tumor. For the interest of time, I will proceed to the next case. The third case is a 5-year-old male child from Gondar, visited outpatient clinic for a complaint of abdominal pain of 4 days duration. The physician reviewed the medical history and completed physical examination, considered acute appendicitis, for which he ordered an abdominal sonography, which revealed a mass, complex renal mass. So you can see how variable would the presentation be. Like this one had presented with an acute abdominal pain, but he had a huge mass. But initially, the physical examination was not thorough enough to pick this huge mass. So we need to stress on the importance of history and physical examination in picking childhood cancer early. So any palpable abdominal mass should be considered as malignant until proven otherwise. We need to do a test to know the true nature of the disease. But until then, if a child has a mass, that's why we have to palpate. We need to palpate the abdomen when a child is coming to the clinic for a well child visit, for a sick child visit, for immunization itself. We have to palpate the abdomen at least once to check for the presence of any abnormal finding. So the cause of the mass could be variable depending on the age of the child. Here is the summary. Depending on the site, you can have different forms of both malignant and benign mass occupying the abdomen and the retroperitoneal space. Knowing the specific diagnosis at this level is not important. What's important is picking it early and then sending the patient for proper workup and diagnosis. So imaging is very valuable here. You can start with plain X-ray, you can do sonography, and then you can proceed to CT scan. But if you are somewhere in a healthcare system, and if you want to do these tests, and if the patient is going to be delayed for having this test, that will contribute for poor outcome. So if you have a child with palpable abdominal mass, the only thing that you can do is just to refer the patient. You don't need to wait. If there's a long waiting queue in the sonography or in the CT, you have to send, because at last they will need these tests in the treating center. So if it is palpable mass, even your history and physical examination is quite enough to refer that patient. So case 3, after proper oncologic evaluation, diagnosis of localized Wilms tumor was made and patient has completed treatment. The other finding that you might probably face often in your in your field of practice would be cytopenias. It could be single lineage abnormality or multiple cell count abnormality. When it is single cell abnormality, that's usually difficult. But when it is pancytopenia or cytopenia alongside with other clinical manifestations, it's much easier. So isolated leukopenia is common following viral infection, but it could be again a sign of malignancy. So patients with isolated cytopenias, they should be followed and checked for response assessment. Bleeding is usually associated with benign conditions, but thrombocytopenia together with other additional symptom could be a manifestation of acute leukemia. And then this needs again proper history, physical examination, and then analysis of the CBC finding. So when there are blasts on the peripheral smear, or when there is unexplained lymphadenopathy, splenomegaly plus cytopenia, this patient should be sent for bone marrow aspiration. Or if there is any mediastinal mass plus cytopenia, or if the cytopenia itself is unexplainable after exhaustive workup, this needs a bone marrow evaluation. So do we need to establish the diagnosis before referral? I don't know I mean, like I would expect most of the participants tonight would be from I would say non-cancer treatment center. So in those centers, there is no need of wasting the time, taking the time to establish the diagnosis. Even if your center is a tertiary care center, if they are not treating childhood cancer, you can send the patient with a history, physical report, and some preliminary tests only. Because settling the diagnosis, including imaging and histopathologic review, will be done in a treatment center. So the ultimate diagnostic test is surgical biopsy. It's a biopsy that will confirm the diagnosis. So as a summary, the common sites of malignancy in children include hematogenous or the blood and the bone marrow, lymphomatogenous organ, and then followed by the brain generally, and then the nervous system, and then the lymph nodes, and then the other organs like the kidney. Frequency varies depending on the age of the child. So each age group has its own peak incidence and type of cancer. So childhood cancer, it might present with signs and symptoms shared by common childhood illness. That's why it makes it very difficult to suspect childhood cancer early and make the diagnosis timely. Optimal management requires high level of suspicion because if it's detected early, it will be optimally treated and then the outcome will be good. So there has to be a high index of suspicion, high level of suspicion by primary care practitioner, and early referral to the pediatric oncology treatment center. So as a recommendation, although a single finding in isolation does not always require an evaluation for cancer, when it's combined, like multiple findings are there, that has to be worrisome, and then that has to initiate referral. So if a child has an isolated symptom which is atypical or persistent, or some symptoms which are not responding for the planned treatment, that should result in referral. But when they came in multiple symptoms and signs, again, that has to be seen seriously. Specifically, isolated symptoms like mass anywhere. It could be in the abdomen, it could be in the bones, in the soft tissue, or any change in the eye, even if it comes as a solitary symptom, that has to be taken as seriously. So I just want to repeat on the warning signs. This has to be seen seriously, and then any child with one or the other manifestations listed here needs early referral and consultation. So we need to discuss with the pediatric oncologist before referral in one way or another. We need to see whether that patient needs referral or not, and that should be done before sending the patient. And we need to avoid referral directly to other disciplines. Like we mentioned, the other patient, they have been rounding to different units and then they wasted their time. So if that's the child, by definition, from birth to 19 years of age, they have to be linked to a pediatric oncology center, and that pediatric oncologist will facilitate the workup and link. Cancer treatment itself is a multidisciplinary decision and discussion. So the pediatric oncologist and the team will involve all the disciplines that will be involved in care and treatment. And try also to avoid doing invasive procedures unless recommended by the receiving doctor. Whether you do biopsy there, unless you have to send the block to the treatment center, or it has to be repeated here. So just for the interest of facilitating the tests, you can send the patient only, and make sure the patient is stable and able to travel before you send them for referral. So this will end the presentation. Thank you for your attention, and we can take some time for questions and answer session. Yeah, that's right, Dr. Gasho. Thank you. That's true. Yeah, in addition to patient factor and then the health system related delays, time to definitive diagnosis, yes, that's also a contributor. Once the patient is in a cancer treatment center, there is a delay to initiate, to get the right diagnosis and then to start treatment. That's That's also a contributor for delayed diagnosis. Yeah, most of them, it's happening outside the hospital, but even within the hospital, it's not, uncommon to see delayed diagnosis and delayed initiation of treatment. Yeah, there's another question. Can a lymphadenopathy anywhere, like isolated occipital lymphadenopathy, be suspected for malignancy? Yeah, that's a dilemma. If it is isolated and if it is only lymphadenopathy with no associated symptoms, that shouldn't be worrisome, but we have to see the size, the growth pattern, and the treatment response for the presumed cause of lymphadenopathy. But if it is solitary and if it is in the occipital region in a child, I wouldn't be much worried about cancer in this case, but it should be followed. Someone mentioned leukemia. Is it curable in Ethiopia? Yes, it's curable. Like it's if it is treated timely and properly, yes, it's curable. But most patients, they abandon treatment, interrupt treatment, or we don't have the drugs by the time when they need it. So because of different reasons, the outcome of leukemia in Ethiopia might be much lower than other countries, but generally, leukemia is curable. Caused by cancer. Yeah, interesting. Yeah, we have mentioned this again. If the headache is persistent, if the headache is in a very young child, less than 4 years old, or if it's associated with additional symptoms like vomiting, or if it's associated with, neurological signs, or if it is, associated with, again, any change with vision, that should be seen seriously, and neuroimaging should be initiated. Yeah. Axillary flickers per se, they don't suggest malignancy, but if a child had axillary flickers, we have to check for other neurocutaneous manifestations of neurofibromatosis and other signs that might predispose the child for cancer. They are not clinical signs of cancer, but children with flickers or children with calculates or children with Irish leaf nodules or any other predisposing clinical manifestation, they should be seen frequently to check for development of malignant or a benign lesion. Yeah, if we suspect gynecologic malignancy in female child, do we refer to pediatric oncologist? Yeah, this is interesting. Yeah, we have cases that we see them up front. Others, they will be sent directly to a gynecologist, oncologist. But whomever is seeing the female child first, they will decide on an immediate discussion. So they will involve the pediatric oncologist, and then the opinion of the gynecologist oncologist will be, will be taken as as a frontline decision, but it will be an immediate decision. Yeah. High detection rate of cancer in LMIC. I don't think it's because of the detection, but rather most children are living in low-income countries. So probably that is something to do with numerical statistics. Otherwise, I don't think there is an increased incidence of difficulty of pediatric cancer diagnostic investigation. I think that's a whole topic by itself, but maybe we can do some session on that. Thank you everyone for attending this
All
session.
right. All right. Thank you, Stock. Maybe if you have one last remarks, if you want to say, and we'll conclude that after that.
Yeah, just want to stress again on the importance of early detection, and then the high index of suspicion is required by the healthcare providers. Whoever is seeing these children up front, they have to always think about this could be childhood cancer. They may not inform the family or the parent, but at least they have to consider it as a differential diagnosis. And then even if they treat for a common condition, they have to, revisit the child. We have to see them again. And whenever they have a suspicious sign, they can reach out to an oncologist, or they can send the patient for better and timely diagnosis, because timely diagnosis is the only way to improve the outcome of children with cancer. But if you continue like this, outcomes will not change in our case, because most patients are coming with delayed presentation. So we have to work on early detection. Everyone who has attended today's session has to pass the message to other colleagues, and then so that we can bring change. Thank you so much.
All right. Thank you so much, Doctor, for the amazing presentation. We hope to see you in another session maybe. And have a good night.
Thank you.